Welcome to another video on odontogenic tumors, where we'll be talking about the adenomatoid odontogenic tumors. I promise you that by the end of this video, you will know about it in detail. For more such videos, head on to our channel and subscribe to our channel. Check out our playlist on oral pathology and odontogenic tumors. So getting right into adenomatoid odontogenic tumor, the key to understanding this lies in its other two names, which are adenoameloblastoma and ameloblastic adenomatoid tumor. All three of these words indicate one thing, and that's the word adeno, right? So this is a recurrent word which means gland or glands. So this implies the glandular or the ductal structures that you see that are present throughout the lesion. Although you will understand this much better as we get into its histopathology, remember that these duct-like structures are not true ducts, okay? These are the way the tumor has proliferated. Adenomatoid odontogenic tumor, it is an uncommon benign tumor and accounts for only about 3.7% of all odontogenic tumors and is mostly associated with an unerupted maxillary canine, as in this diagram. It is defined as a tumor of odontogenic epithelium with varying duct-like structures and varying degrees of inducive changes in CT stroma. So remember our classification on odontogenic tumors, where we mainly classified them into benign tumors and malignant tumors. The benign were further classified into one of the categories which said odontogenic epithelium without ectomesenchyme. Okay, so this is purely a result of odontogenic epithelium. Fine. There is still a controversy whether it is a neoplasm or a hamartoma. And its histogenesis, there is no exact known cause like all odontogenic tumors, but it is believed to arise from the components of the enamel organ, the reduced enamel epithelium, the rest of malar cells, and more recently and importantly, the remnants of the dental lamina. Okay? Its clinical features, these are quite unique compared to other odontogenic tumors because here you see a predilection in younger individuals below the age of 20 years, a predilection in females, and especially the site of predilection is the maxilla. Right? So about 2/3 of all the tumors, they occur in the maxilla and even more so in the anterior maxilla. It is 2/3 of the times associated with an unerupted maxillary canine. Right? So it's associated with an unerupted maxillary canine. Now, if you paid attention to the statistics here, you will understand why adenomatoid odontogenic tumor is also called the 2/3 tumor. And this is because 2/3 of it is occurring in females, 2/3 of it in maxilla, 2/3 of it in the anterior maxilla, and 2/3 even more so with the maxillary canine. So all in all, this is why it is called the 2/3 tumor. It presents as a slow-growing, painless, asymptomatic mass. Okay, this is typical of a non-invasive benign tumor, and it is usually related to an unerupted tooth. So it might be impinging the eruption of another tooth. Now, although it is usually small in size, sometimes it can be big also, and in such cases it can cause expansion of the cortical bone as well as elicit fluctuation. So far we were talking about the intraosseous form. Now in certain cases, although uncommon, it can also be present extraosseous or outside of the bone. Here it appears as a pink colored mass on the gingiva. Okay, so intraosseous and extraosseous. In its radiographic features, again, it appears as a well demarcated, almost unilocular radiolucency, which is small in size, around 1 to 3 centimeter. Now, on the basis of this, we can classify it into two types. One is the follicular and the other is the extrafollicular. So obviously the follicular, it is associated with a tooth, right? So this is the follicular and it is associated with an unerupted tooth. The extrafollicular, it may be present in various other sites such as between the roots of two teeth or at the apex of the root of one teeth or a location completely away from these. Now, so far, after listening to the clinical features and the radiographical features, you would have understood that it very closely resembles the dentagerous cyst. And at this point, the dilemma is, can I clinically and radiographically differentiate it from a dentagerous cyst? Yes, you can. So there are 2 points here. One is its relation to the CEJ. Now we know that dentigerous cyst, it always extends only up to the cemento-enamel junction, right? So this is the cemento-enamel junction. But the AOT, it can often extend beyond the CAJ, as in this example. The other thing is the presence of certain calcifications. So often you see snowflake calcifications which are detectable in this radiolucency. Okay, so there is a presence of extension beyond CAG and calcifications. In its histological features, let's first look at the macroscopic features and then the microscopic features. So macroscopically, again, it is a non-invasive benign tumor. So it appears as a well-defined, it's almost spherical or round with a thick fibrous capsule. Okay, it's got a thick, complete fibrous capsule. And when you section it, it will either appear solid or cystic. There might be the presence of several large calcified masses within it, and sometimes you might see a whole crown of a tooth embedded in it, right? So this is how it appears macroscopically. If we go into the microscopic features, these are quite interesting. Let me take you to the diagram. So its histopathological pattern, it is very interesting because there is the proliferation of different types of cells in different types of patterns. Okay, that's it. Different types of cells as in spindle-shaped cells, cuboidal cells, columnar cells, and variety of patterns as in what you see here, the rosette pattern, the ductal pattern, the convoluted pattern, right? So variety of cells and a variety of patterns. Dominating the lesion is the proliferation of spindle-shaped cells or polyhedral cells in nests and sheets. Okay, so as you can see at the top portion of the diagram, I've tried to indicate sheets of cells. So dominating the entire lesion is the proliferation of spindle and polyhedral cells in nests, sheets, and sometimes strands. Okay, so these were the cells and these were the patterns. Apart from that, you see the presence of some intraepithelial structures. So these are some areas of eosinophilic amyloid-like material. Then you have some areas of foci of calcifications, right? So intraepithelial structures are amyloid-like material and foci of calcifications. So the final thing is the proliferation of these ductal cells, right? So in the first video, I told you that the reason for calling this the adenomatoid tumor was the presence of various duct-like structures. So let's talk a little bit about these duct-like structures. Now these are lined by one layer of cuboidal or columnar cells which have a nuclei which is polarized away from the lumen. Okay, so low columnar or cuboidal cells with a nuclei polarized away from the lumen, and the lumen often contains an eosinophilic substance, and apart from that, a hyaline ring of varying thickness. Okay, so it contains eosinophilic substance and is lined by a hyaline ring of varying thickness. So this is all we have in the histology. Let's go again over it. There is a proliferation of different types of cells such as spindle, cuboidal, and columnar in a variety of patterns like the rosette, ductal, convoluted, and sheets and nests. Apart from that, you have intraepithelial structures such as eosinophilic amyloid-like material and foci of calcifications. Then you also need to talk a little bit about the ductal structure. With this, we have come to the end of the video. A quick note on treatment and prognosis. Because it is a benign tumor and it has a very good fibrous capsule, it evaluates very easily and its recurrence rate is also very low. Before concluding, I have 3 questions for you, which is 1. How do you differentiate adenomatoid odontogenic tumor from the dentigerous cyst? Why is it called the two-third tumor? And give me 2 histological patterns points regarding adenomatoid odontogenic tumor and also the reason why it is called the adenomatoid odontogenic tumor. With this, we're going to wrap it up. I hope you enjoyed this video. I hope you learned something out of it. And if you did, please make sure to like and subscribe and support me further in this. I hope to see you in another video really soon. Until then, I hope you have a great day ahead.